Good afternoon, and welcome to this webinar, Zika virus impact, issues, and updates. My name is Chris Campanile. I'm a family physician at Coastal Hillside Family Medicine in Pawtucket, Rhode Island, and I'm a physician consultant with the QIN-QIO here in New England. I'll be your moderator for this event. A few things I wanted to mention before we get started. The format for today will be a short presentation by each of our panelists regarding their perspectives on the Zika virus, followed by a question and answer session. During that time, you can use the chat feature as well as the phone line to ask your questions. We've applied for CEU and CME credits for this presentation. At the end of the webinar, there's a survey that will provide the opportunity to complete necessary information to obtain these credits. We've also reviewed and confirmed that there are no relevant conflicts of interest today from either today's speakers or the planning members of this activity. Our first presenter is Jeff Bradford, who's a clinical professor at the University of Rhode Island. His specialties include infectious disease, emergency preparedness, and population health. Dr. Bradford.
Thank you for that introduction. We'll talk a little bit about the objectives. The next slide. No disclosures there. We'll talk about the epidemiology and clinical manifestations, testing, reporting, management of Zika virus disease. Go to the next slide, and we'll talk a little bit about what the Zika virus is. The single-stranded RNA viruses are arbovirus-borne viruses, so hence arbovirus. It's a little-known virus, and you see an electron microscopy there of what the virus actually looks like. It was isolated recently in 1947 in the Zika forest, hence its name, Uganda. It's a flavivirus, similar to dengue, yellow fever, West Nile, and Japanese encephalitis. So it's transmitted in a few ways, which makes it a little unusual. The bite from an infected mosquito is the primary way. Maternal fetal transmission, which will go into intrauterine and perinatal. Sexual transmission from infected male partners. There have been documented cases of laboratory exposure, and there's some theoretical cases based on other flavivirus transmission like West Nile virus with blood transfusions, organ and tissue transplant, fertility treatment, and including breastfeeding. So what we don't know about transmission is how often men with Zika never develop symptoms, can have virus in their semen, or if they can pass Zika through sex and how long. We don't know if sexual transmission poses a different risk for birth defects in pregnant women than mosquito-borne transmission to women who are pregnant in areas of local transmission. And until last week, we didn't know if a woman with Zika can pass the virus to her sex partners, but our friends at CUC published a report of suspected female-to-male sexual transmission of Zika virus in New York City. 27-year-old female who traveled to the Zika area and prior to developing symptoms had unprotected sex with a male who then developed Zika, and she developed symptoms as well, and both tested positive. So in terms of travel or unprotected sex, we still have some guidelines from April that for women and men, if you have Zika symptoms, really the essential, what I said before, the key factor is unprotected sex. So protected sex should prevent Zika transmission. So it's seen at least 8 weeks after symptoms start for women. Men, we take an abundance of caution. It's at least 6 months after symptoms. So if a man has symptoms, and remember, only 80% of people who have Zika are asymptomatic. So if you have symptoms, you have to wait 6 months. Zika virus has detected in semen for up to, I think, about 40 days. If you have no symptoms, same kind of recommendations. Again, abundance of caution. These may change with that new female-to-male transmission, but right now, 8 weeks after exposure for both women and men. Now, if you live in areas of Zika transmission, so in the Americas and American territories, Puerto Rico, American Samoa, and the Virgin Islands, again, same sort of recommendations. To prevent Zika transmission 8 weeks after symptoms start, 6 months for men, and if you have no symptoms, still recommendations are to abstain or use condoms. Now, sexual transmission is there's an interesting report from Rio de Janeiro from some researchers there looking at confirmed cases of Zika. This is actually a chart. The blue line, if you see that, is men. The first column and the second column is green in women. And in women of childbearing age, there's about a 30% increase. This is dengue, again, another disease transmitted by mosquitoes. So a 30% increase in women who are diagnosed with dengue. So that's sort of a control measure of mosquito-borne viruses. You go to the next slide, though, there's actually a 90% difference in women who are between 15 and 65 who have positive Zika. So it's thought that sexual transmission really affects women more often, in particular sexual transmission, women of childbearing age. So mosquito vectors in the U.S., on the top slide is the Aedes albopictus. This really shows, importantly, where mosquitoes have been found or trapped. They don't show the concentration, nor do they show the risk of Zika spread. So if you live in an area in the U.S. where you see Aedes albopictus or Aedes aegypti, you're going to see higher densities in places like Texas, California, and Florida. But we do not have local transmission. The next slide really shows the most updated numbers from the CDC. Again, Zika virus disease and congenital Zika virus infection are nationally notifiable conditions. You see about 1,300 travel-associated, non-locally acquired, 1 lab, 14 sexually transmitted, probably 15 now, and 5 Guillain-Barré syndromes. In the U.S. territories, it's flipped, right? Travel-associated from other places to our territories, 11. Locally acquired, dramatically increased number 29 and 05. And again, importantly, it's unknown what our sexual transmission is because there's local transmission by mosquitoes. But a smaller case of Guillain-Barré syndrome. Pregnant women, this is updated as of July 7th, 346 in the U.S. states and District of Columbia, 303 in the U.S. territories with our pregnancy registries and surveillance system. So what does this look like? Again, 80% are asymptomatic. What you do see, if you do see symptoms, are conjunctivitis, fever, rash, and joint pain, sometimes muscle pain and headache. And when we compare it to other diseases, what really stands out, since dengue is prevalent in a lot of the areas of local transmission, you see a lot less rash, and with Zika you don't see shock and hemorrhage. We do see, fever. Also particular to Zika is that conjunctivitis, which you don't see with dengue and chikungunya. So testing is also a little difficult because, again, you have so few people who are symptomatic, and people may develop symptoms in only a short period of time to identify. If it's less than 5 days or 5 to 7 days, you can do first transcript-based PCR. Greater than 7 days, you're really using IgM serology there. So recommendations are for symptomatic people living in an active Zika transmission area or who recently traveled or who've had unprotected sex, again, current as of today, with a non-confirmed Zika virus infection. Blood, semen, and urine is not recommended, although we have found Zika virus in those fluids. And they may not accurately identify Zika virus or the man's risk of passing it to sexual partners. Laboratories to do this, again, this is working to expand, CDC is working to expand diagnostic testing in states, performed at CDCs in a few state health departments right now, and contact your state health departments to determine how to do diagnostic testing. So there's no vaccine yet. We are embarking on human trials, I think, in a few months. So that's been a really positive statement with vaccines using DNA reverse engineering. We're actually getting closer to vaccines, probably closer than we thought just a few months ago. And really symptomatic treatment, rest and fluids, acetaminophen for fever and pain, and avoiding aspirin, again, because dengue presents with similar symptoms, and that could exacerbate possible hemorrhage. So if you look at testing of pregnant women with possible Zika virus exposure who don't reside, so this would be probably the majority of those listening, if there's one or more signs and symptoms within 2 weeks of travel, use serum testing, that IgM. It can be offered to asymptomatic pregnant women with possible exposure, again, sex without a condom with a symptomatic male or history of travel to an area with active Zika virus transmission. It's not currently recommended for pregnant women with possible sexual exposure if both partners are asymptomatic, which is probably a large reservoir there. If you take care of pregnant women who reside in the area of active Zika virus transmission, testing performed at presentation. We're not testing everyone. If a woman does not report one or more signs of disease, you can do IgM testing upon initiation of prenatal care, and if negative, in mid-second trimester, and repeat testing if symptoms develop. So how do we prevent it? Again, do your homework. There's lots of constantly updated information on the CDC Zika page. Advise pregnant women right now in all trimesters to not travel to areas of Zika. If they must travel, again, standard protection from mosquito bites, avoiding sexual transmission, either abstaining or using condoms during and after travel. The next page just sort of shows where it is focused in the Caribbean, Southeast Asia, and South America, and Mexico right now. Puerto Rico is also included. So the steps to protect, this is from the March of Dimes. We see there are Zika response kits there. There are larvicides to put in standing water. There's permethrin spray in the middle there to treat clothing. There's condoms, and there's sprays with DEET. There's several other ingredients that can be used on children and pregnant women. EPA approved sprays. So use spray, keep mosquitoes away. Say you will embrace the chill, use air conditioning or window screens. Again, if you're taking care of patients who don't have that, they're at higher risk. If it's wet, if it's a threat, remove still water. Get protected, not infected. Again, wear clothing to protect bites, and use a condom to prevent sexual transmission. And if you suspect, then connect. If you've gone to an area with active Zika transmission, if you've been bitten by mosquitoes, and or if you develop symptoms, make sure that when you develop symptoms, you contact your healthcare provider.
Thank you, Dr. Bradford. Our second presenter is Erica Hardy, who is the Associate Director of the Women's Infectious Disease Service at Women and Infants Hospital in Providence, Rhode Island. Her specialties include infectious disease and obstetric medicine. Dr. Hardy.
Thank you. So from my objective, I'm going to talk a little bit first about prevention and preconception counseling because that comes up a lot in our practice. Briefly, a bit on the impact in pregnancy of Zika. And then again, like Dr. Bradford talked about, some screening and testing recommendations for mostly focused on pregnant patients. And then some areas of uncertainty because, as we've mentioned, this is a moving target. We're learning more every week, every day. And so it's good to stay up to date. So remembering who is at risk in pregnancy. So the main ways to be at risk for Zika virus in pregnancy is anybody who's traveled or lives in an area with active Zika transmission. So really knowing what those areas are. And then sexual transmission. So having unprotected sex with a male who has had travel to an area with active Zika transmission or resides in an area with active Zika transmission. And then there's these other things that we're learning more about in terms of blood transfusion, organ transplants, lab exposures, and more to come on that. But those are the main risk factors for Zika infection in pregnancy. So what is the risk of Zika in pregnancy? So it can be passed from mother to fetus during pregnancy and around the time of birth. So throughout the entirety of pregnancy. Infection around the time of conception really is unknown if that's able to affect the fetus. Looking at other viruses that are similar, such as CMV, parvovirus, they are able to infect if there's infection and viremia around the time of conception. So that may be the case for Zika. We just don't know yet. Even though Zika virus has been detected in breast milk, there's no reports of transmission during breastfeeding. Infection in pregnancy can cause birth defects. So the ones that we hear the most about are microcephaly, or small head. And Dr. Smith is going to talk about that, which goes along with brain defects, growth restriction, and then other central nervous system findings, so eye defects, hearing loss, and even fetal loss. So preconception counseling, thinking about being prepared and prevention. So because of a lot of the uncertainty surrounding transmission, and we seem to be hearing more and more reports every day, we're still learning about timing and fetal effects. Counseling really is complex. It's important to step back and remember that there hasn't been any evidence of Zika transmission or causation of congenital infection after the period of maternal viremia, so there seems to be a limited time period where Zika can be passed from mother to fetus. The incubation period from infection to contact to disease is about 3 to 14 days, so up to 2 weeks, and then after symptom onset, it seems like Zika viremia lasts a few days to a week, and the longest report in the literature of viremia is about 11 days. So when we think about preconception counseling, there's a lot of awareness out there, and it's been in the news. So what should we be telling patients who are not pregnant yet, but thinking about becoming pregnant? So things you want to include when you're counseling your patients are, what are the signs and symptoms of Zika virus disease? So a lot of the things that Dr. Vackert talked about. What's the risk of getting Zika in pregnancy? Making sure patients are aware of that. Making sure they know recommendations. So if there's an isolated travel or a period where they're in an area with active Zika transmission, women should wait at least 8 weeks after symptoms before attempting conception, or waiting at least 8 weeks after WIC. There's no data available really for women with asymptomatic infection. We talked about 80% of patients with Zika who do have Zika virus are asymptomatic, but thinking back to the incubation period, the recommendation is for somebody who's entered a Zika risk area or had unprotected sex with somebody who may be at risk for Zika, the woman should wait, again, at least 8 weeks from the last date of possible exposure before attempting conception. So 8 weeks for either. You want to be sure to provide information strategies to prevent unintended pregnancy, so providing women with information about effective contraception, and the CDC actually has some really nice information sheets on this, both in English and in Spanish, which are worth looking at. Educating about consistent and correct condom use can decrease the risk of sexual transmission, so we think protected sex with barrier contraception, like condoms, probably prevents the transmission, so making sure women know how to use condoms and men know how to use condoms correctly. And then other prevention strategies, so knowing what the areas of risk are. So before you travel, knowing if there is active transmission, or depending on where you live, knowing if there's active transmission in your area. Knowing that DEET is safe to use in pregnancy. It's the gold standard for prevention of mosquito bites, and it's absolutely safe to use in pregnancy. And then other prevention things, such as mosquito nets, permethrin-treated clothing, if you are going to travel to an area where there is active transmission. This applies to men, too, so preconception counseling for men, not to forget about, letting them know that sexual transmission can occur. We're still learning, again, more and more about this. So data are limited, but the CDC is keeping us up to date. As of the MMWR in April, I believe the CDC had reported 7 cases of confirmed sexual transmission. Looking through those cases, it's important to see that really in all the cases, the men have symptoms, and transmission really seems to occur during a period of symptoms or viremia. So it seems like there's this time-limited window where transmission is most likely to occur. We do know that Zika virus has been found in suppressor sites such as semen, but the duration and pattern of Zika in semen is not well understood, and it's not known just if it's present there, whether or not it's still able to transmit to a female with sexual contact. So how do we counsel men? So if a male has confirmed or suspected Zika, so that's based on clinical illness, like if they had symptoms that were consistent, the counseling is to consider abstaining from sex or using condoms for 6 months after illness onset, and that is because of the detection of Zika virus in the semen, even though we don't know if it's transmittable out that far. If a male had travel risk but no symptoms of Zika, then again the recommendation is 8 weeks to abstain or use barrier contraception, again with the caveat that you could be more conservative and recommend 6 months because of the asymptomatic disease, although remembering that it appears that sexual transmission occurs when the male has symptoms. And then if a male resides in the Zika risk area but has no symptoms, again, the CDC's recommendation is consider abstaining from sex or using condoms while active transmission persists. And of course, if the male does have a pregnant partner, using condoms consistently and correctly for the duration of pregnancy. So who do we test? So not everybody, and so it's important to keep looking at the CDC recommendations, and I'm going to show some nice tables that they've outlined, and that's really what we use to decide who to test and how to follow them. So testing for sexual transmission prior to conception really isn't recommended, and that's because we don't know what to do with the information. The duration and pattern of shedding of Zika virus isn't very well understood, and so we can test, but we don't know if we should be reassured by a negative test or concerned with a positive test. So a pregnant partner with a possible sexual exposure should be tested if either she or her male partner develops symptoms consistent with Zika, and again, that would be one or more of the following within 2 weeks of possible exposure. So fever, rash, arthralgia, conjunctivitis, continuing to remember really those 4 symptoms are most important. And then couples in which a woman is pregnant and the male partner has traveled to or resides in a Zika risk area, important to counsel about using condoms for the duration of the pregnancy. What testing is available? So we went over this a little bit in the first part of the presentation. There is, if somebody comes back and they have symptoms less than 7 days, then you can send the PCR in the serum. If it's less than or equal to 14 days, there is a urine test. You can do PCR in the urine for that as well. After that, you really do need to use serology, so IgM with neutralizing antibodies after that, and serum collected up to 12 weeks after illness onset. So really, we test for IgM 2 to 12 weeks after onset. And the Department of Health in your state is going to be helping figure out which test to send, and so you'll be in contact with them if you are considering Zika testing. They do have to approve it. There's other testing we have the ability to do on tissues, such as placenta. Again, the state health departments approves testing and send testing, so working very closely with your state health department is important. The CDC is working to expand testing sites, and so there'll be more to come on that as well. So in pregnancy, again, testing recommendations are for pregnant women with clinical illness, 2 to 12 weeks again, during or within 2 weeks of travel or possible sexual exposure. So that includes patients while pregnant or within 8 weeks prior to conception. So there's a little bit of a window there as well. And again, we don't recommend testing asymptomatic partners. The next slide just goes over what I just spoke about. There's interim diets for pregnant women who have possible exposure to Zika virus, but they don't reside in the Zika transmission area, and we'll talk a little bit about that. And then, so that basically, if somebody has signs and symptoms of Zika virus disease, on the left side of the slide, then we do offer testing for them. If a woman doesn't report symptoms, then again, serum IgM testing can be offered, and we usually do that upon initiation of prenatal care, and then if it's negative, in the mid-second trimester. And again, if symptoms ever do develop, repeat testing is offered. And that, the next slide, this chart here is for women who are residing in an area with Zika transmission. So again, they split the chart up patients with symptoms and patients without symptoms testing. And then while you're waiting for testing, you want to be doing serial fetal ultrasounds as well. So we do fetal testing during pregnancy, including ultrasounds, looking for some of the things like microcephaly, intracranial calcifications, any brain or eye abnormalities. The issue with that is you may not detect abnormalities until late second or third trimester, and that's why we do recommend serial ultrasounds, and we're doing them about every 4 weeks. Briefly, the CDC has set up a Zika virus pregnancy registry, so there's 24/7 consultation service, and the numbers are there. And then they're going to be keeping track of pregnant women with Zika virus, so we can hopefully learn more about our pregnant patients in the U.S. In terms of testing amniotic fluid, we really are, there's no standalone guideline. We are really individualizing testing for women, so referring to MFM and making a case-by-case determination about when to send amniotic fluid. We're still learning about the sensitivity of PCR and amniotic fluid. The optimal timing for amnio is not known at this point, so we're really individualizing that decision. Areas of uncertainty. So again, we really have to learn more about the characteristics and duration of viral shedding, especially in sequestered sites such as semen. So that's going to help tell us a lot more about sexual transmission. We're again learning about performance of testing in amniotic fluid, and as we do more amnios, we're going to be learning more about that. And then important to know, and this is a good segue into Dr. Smith's presentation, if Zika virus testing is pending at the time of delivery, if you have a pregnant patient that comes in late, you do want to try and collect placenta and cord blood samples because that's going to be important as well. So I think in conclusion, really preconception counseling is important, so people have the right information. Understanding is changing, so keeping up to date, especially with the CDC website. Remembering not excluding men from counseling, so counseling men and women is important. And then really it's just another illustration that we're a global village, so screening for exposure, not only Zika, but other diseases is very important. Thank you.
Thanks very much, Dr. Hardy. Our third and final presenter is Michael Smith, who is a pediatric infectious disease physician at Hasbro Children's Hospital in Providence. He also serves as the Associate Medical Director of the Department of Epidemiology and Infection Control at Rhode Island Hospital, and is the Medical Director of the Pediatric Antimicrobial Stewardship Program at Hasbro Children's Hospital. Dr. Smith.
Thank you. In regard to diagnosis of Zika virus in newborns, the Center for Disease Control has issued guidelines in their morbidity and mortality weekly report. It's available on their webpage. If microcephaly or intracranial calcifications are detected prenatally or at time of birth, you should perform Zika virus testing and other clinical evaluation of the infant. I'll go into the details of that on a later slide. If you have positive or inconclusive tests for Zika virus infection in the infant, you should report the case to the local health department and then
yeah, you should. I mean, I've done this. They're going to have questions and answers and everything. I'm done.
in the patient.
Sounds like there's somebody coming.
For other possible etiologies.
Excuse me, could people please mute your phones, or operator, could you please mute everyone's line so we're not interrupting the speaker? Thank you.
Please continue, Dr. Smith.
So, as a reminder, microcephaly refers to an abnormally small head with the head circumference being smaller than the third percentile of the mean or 2 standard deviations below the mean. And this is also adjusted for gestational age to account for babies who are born premature. It's also important to understand that microcephaly can be caused by other reasons than Zika virus. And so any case of microcephaly should be evaluated for genetic, disruptive reasons such as stroke, as well as infection, the most common being cytomegalovirus, toxoplasmosis, and rubella. In regard to the test for Zika virus in newborns, you can do molecular testing, which is a reverse transcription PCR for viral RNA, or serologic evaluation, which would include an ELISA. This more complicated algorithm is when you are evaluating a patient where you suspect Zika virus infection, but there's no evidence of intracranial calcifications or microcephaly either during the pregnancy or shortly after birth. In short, if the woman has had evaluation during pregnancy that is positive or inconclusive for Zika virus, then the child should be tested for Zika virus as well as having a detailed physical exam. If the mother has not had Zika virus testing, then she should be tested. If it is positive or inconclusive, then again the child should be tested. If it is negative, then the child should be evaluated as any other newborn for any other problems. For recommended clinical evaluation and laboratory testing for infants with possible congenital Zika virus infection, you should do a comprehensive physical examination. Evaluation for neurologic abnormalities, dysmorphic features, splenomegaly, hepatomegaly, and rash or other skin lesions. You should conduct a cranial ultrasound unless prenatal ultrasound results from third trimester demonstrated no abnormalities of the brain. You should evaluate the hearing. You should also have an ophthalmologic evaluation before discharge from a hospital, or at least within 1 month after birth. Recommended clinical evaluation and laboratory testing for infants with possible congenital Zika virus infection. For infants with microcephaly or intracranial calcification, additional evaluation includes the following: consultation with subspecialists to include a clinical geneticist, a pediatric neurologist for recommendations for potential brain imaging, and as well as evaluation for other congenital infections. In this case, it would be useful to consult a pediatric infectious disease specialist. You should also take basic laboratory tests to include complete blood count, platelet count, liver function, and enzyme tests. And should also consider genetic or other teratogenic causes. Now, the sentinel event that brought this to our attention was the microcephaly outbreak in Brazil. Between the 22nd of October of 2015 and the 12th March of 2016, 6,480 cases of microcephaly or CNS malformations were reported in Brazil. This included, unfortunately, 182 deaths. To put this in perspective, from 2001 to 2014, for Brazil, they averaged 163 microcephaly cases a year. In looking at the prevalence of microcephaly among newborn children, in the 15 states with laboratory-confirmed Zika virus transmission in Brazil, 2.8 per 10,000 live births were present, whereas in the 4 states without confirmed Zika virus transmission, there is only 0.6 cases per 10,000 live births, and this difference was highly significant. In emerging infectious diseases, here we have pictures of microcephaly of some of these infants in Brazil. You can see the abnormally small head, and then on the right you'll see the CT scans showing the increased ventricle size, the decreased brain tissue, and calcifications. This chart shows in October of 2015, the spike in cases that they had, showing that this was truly an increased number and not just an anomaly. In a study published in Emerging Infectious Diseases, they looked at 104 children who had microcephaly in Brazil. The mean head circumference was 29 centimeters. They looked at mothers' mean age and found it to be 25 years with a range of 15 to 43, so maternal age was not a factor in this. 59 of the women recall rash during pregnancy. They conducted neuroimaging on 58 of the children and found calcifications in 93%. They also found malformations of cortical development in 69%, to include lissencephaly, which is a relative smoothness of the brain, pachygyria, which is a decrease in the number of folds in the brain, and agyria, which is an absence of folds in the brain, or a flat brain. The New England Journal of Medicine published a series of neuroimaging showing children with the microcephaly. You can again see the increase in ventricle size, the decrease in brain matter, and the calcifications. Now, in regards to the timeline of infection, it's thought that the end of the first trimester and the beginning of the second trimester are the times when infection can cause the most damage to the fetal brain. New England Journal of Medicine published a timeline of such a pregnancy. If you look at this timeline, a pregnant mother traveled during the first trimester to an area of active transmission. She reported at approximately week 12 to 13 of gestation onset of acute disease that include fever, eye pain, myalgias, and rash. She returned home and she had ultrasounds done in weeks 16 and 17 that were normal. She, at this time, also had blood samples taken that showed that she had laboratory evidence of Zika virus infection. At week 20, they conducted another ultrasound and unfortunately found severe fetal brain abnormalities, and pregnancy was terminated at this time. Subsequently, blood and tissue samples from the fetus were found to be positive for Zika virus. Potential complications for Zika virus infection in children include severe intracranial calcifications, severe cortical malformations, ventriculomegaly, cerebellar hypoplasia, abnormal hypodensity of white matter, and ocular findings. Here is a picture from Lancet showing chorioretinal scarring. Another potential complication includes Guillain-Barré syndrome, which is immunological complication that occurs with other infections that clinically present as an ascending flaccid paralysis. What happens is that the myelin sheath is attacked by the immune system that inhibits the neurons from firing normally. A study published in Lancet showed a Guillain-Barré syndrome outbreak associated with Zika virus infection in French Polynesia. They looked at cases from October 2013 to April of 2014. And this is a time when they had an increased number of Guillain-Barré syndrome cases as well as Zika virus reported. It was a case-control study. They looked at 42 patients with Guillain-Barré syndrome and found 98% of them had anti-Zika IgM or IgG present in their serum, whereas only 56% of the controls. So this was a highly significant difference. And this was the first evidence published in the literature that was linked GBS with Zika virus. Zika virus is also associated with mortality. It can cause fetal loss. The mortality varies. A lot of it depends on the certainty of the diagnosis. We just don't know what the denominator is at this point of how many people have actually been infected with Zika virus. It also has to do with the gestational age of infection. So in a study in The Lancet, they found that the mortality rate varied depending on the certainty of the infection, anywhere from 40 per 1,000 cases to 58 per 1,000 cases. Recommended long-term follow-up for infants with possible congenital Zika virus infection includes reporting to the state, territorial, or local health departments, conducting additional screening at age 6 months, evaluating the head circumference and developmental characteristics and milestones throughout the first year of life. What will probably be found out at a later time is that there will also be subtle neurological and neurodevelopmental defects in these children that aren't noticed at birth but will be found longitudinally later in life. You should also use appropriate consultations with medical specialists to include pediatric neurology, developmental and behavioral pediatrics, and physical and speech therapy. At this point, there is no treatment, there's no vaccine, although there is under development a repurposed West Nile virus vaccine that will probably not be available for at least 1.5 to 2 years.
Thanks very much, Dr. Smith. At this time, we are going to open the phone lines. You can unmute your phone line by pressing #6, and you can also post questions using the chat feature on this webinar. So while we're waiting for the first questions from the audience, I just wanted to make a comment and questions. As a primary care provider here in Rhode Island, the practical information I take away from this is that when I'm seeing women in a preconception frame of mind who might have an infection, they should wait 8 weeks until trying to conceive, and for men that had infection, wait until 6 months. It's very helpful for me to know that DEET and permethrin are useful and safe to use. And I think about the people I see in the summer, and I see people with enteroviruses, I see people with arboviruses, and I see people that present with rashes, fevers, muscle aches, and headaches. And I'm just wondering how, and so along with testing for, say, Lyme or ehrlichiosis or babybiosis, or thinking about even summer enteroviruses or meningitis, the conjunctivitis to me is helpful, and I don't know how much people know about how specific it is to this particular infection, but I feel like I should, if I saw that was conjunctivitis, then I should also be sending a sample for testing for Zika virus.
I think important to remember if you are practicing in an area with active transmission. If not, then you likely wouldn't have to. And probably if the patient wasn't pregnant, right now we're mainly testing pregnant women because it's the CDC right now and a few other sites are the only sites that are doing the testing. So not wanting to overwhelm the system, they're working on testing pregnant women because otherwise it's really a mild illness. So, and then but also keeping in mind as a primary care provider, taking a good travel history. For many things, for dengue, for malaria, you want to know if they just got back from an area because you certainly would test and treat that differently. So even though Zika virus we don't have any treatment for, it's supportive care. In general, it's a very mild illness. Making sure to, in all practices, really learning how in this day and age to sort of make system changes to implement that travel history is a really important take home, I think. So.
And for many places across the country, this became part of the normal way of business with the Ebola virus outbreak because it became very important if someone had a travel history and a fever and non-specific signs that they get to the bottom of what exactly their exposure history was.
And we do have a question on the chat line. And it reads, I realize presentations were prepared earlier in the week, but any thoughts on the recent report of familial causal contact transmission?
So this is Jen. I read about that in the New York Times, I think this morning. And I think, the important thing, and I believe the CDC and Tom Frieden, the director, is that there's no cause for alarm both in Utah. So I guess a brief synopsis is, there was a Zika death in the U.S. in Utah, a person who was infected with Zika that had chronic medical conditions, and a caregiver ended up testing positive for Zika. And the caregiver it is not an area of local transmission, as is anywhere in the U.S. right now. The mosquitoes aren't there, so not mosquito-borne and not sexually transmitted. We were talking about this a little earlier before the talk, and we think that Zika has been found in saliva and urine, as well as blood and semen and breast milk. So in this case, one of the newspaper report said that there were very high concentrations of Zika in this gentleman's blood, so perhaps that translates to other tissues and perhaps to those other fluids, and perhaps those fluids were exposed to the person who tested positive and had recovered. I don't know if my colleagues have comments on that.
No, that would be the most likely route of infection would be exposure to some sort of bodily fluid through just casual care for this caregiver.
But just like the recent report of female-to-male transmission, it adds a whole other dimension to this. And again, I think we still need to be focused on, I see Zika, as the World Health Organization as a public health emergency. But the prevention that I talked about in terms of preventing mosquito transmission and preventing sexual transmission also prevents all sorts of other diseases, the other arboviral diseases you prevent. It's great to use mosquito repellent. It's great to use permethrin. We are all in New England in Limeville, and so preventing bites from any kind of arthropod hopefully has the added bonus of reducing incidence of other diseases.
And I think we think about some of those things, for the pediatricians and obstetricians that are listening, CMV virus. So that's shed in the urine of toddlers when they are infected with CMV, and they may be asymptomatic. And so we talk to pregnant women about really good hand washing when changing diapers and things like that. So, when, caring for people, just trying to use universal precautions and good hand hygiene, et cetera, is going to help prevent a lot of infections.
I read, too, that I don't know if this was substantiated, but that because the testing goes to the CDC, and I heard you say they're trying to set up outside the CDC testing sites, but that someone had posted a comment that it took much longer than expected to receive results, maybe 6 or 8 weeks, when it should have been 2 to 3 weeks.
Well, depending on where you are in the country, they are starting to do testing at state health departments. At the state of Rhode Island, they now do serology and molecular testing at our own health department, so it varies state to state.
And there's rapid tests being developed too, I guess primarily for areas, areas of lower socioeconomic status, and so we have a inexpensive, easily deployable sort of blood spot testing using the same technologies patient tests for HIV and other places and other viruses that occur in these fluids. So I think that we're going to see deployment of those tests as they get approved. There's one, I think, that has been emergency approved, but I don't know what the status is on its manufacturer.
Another question, which you probably can all see, too. After testing positive and having the virus run its course, what are the risk factors for becoming pregnant?
Yeah, so that has come up. It doesn't appear that there's any risk to future pregnancy. So after somebody does have the illness, it may even be protective. Someone who's had the illness, we talk about waiting the 8 weeks until infection is passed. And then after that, there doesn't appear to be any risk to future pregnancy.
Along those lines, too, Erica, I think you had mentioned, or maybe Dr. Smith, that it seems like either transmission or the effects on a pregnancy are less deleterious in the second half of the pregnancy versus the first half. I don't know if that's felt to be true enough that you would actually counsel a woman, say, who was going to be traveling or not to a Zika-infested area, who was well into her third trimester versus in her first.
Right. Yeah, I mean, I think extrapolating the other viruses, I keep bringing up CMV, but, you know, if you think about it, just like the New England Journal case that Dr. Smith brought up, we do think infection early in pregnancy while there's still organogenesis and the brain is still developing is probably, there's more time to develop all the effects. Whereas later on, you know, there's less time, most things are fully formed. However, you know, like with other viruses, there still can be effects on the central nervous system, so hearing, eyes, you know, so I would probably, you know, depending on the patient, you can talk about all of that. It's probably most risky early in pregnancy, but there's still unrisked, and there's probably unknown risks for later in pregnancy too, so it's really a moving target.
And it's biologically plausible that infection during the later stages of pregnancy might have more subtle effects, such as the hearing, vision, neurodevelopmental things that might not be recognized until much later.
Yeah, you might not notice it at birth, and that's why it's important to be following these infants.
And then from a public health status, I mean, the New England Journal timeline case that Dr. Smith mentioned, you know, that was at the end of the first trimester, but there's also it's another unknown, is what happens in women who, again, unintended pregnancy, 50% of pregnancies are unplanned. So this goes into preconception counseling for you, Dr. Campanile, in primary care. You know, anyone of childbearing age needs to be aware of this, and when they're traveling, and to, you know, have protected sex or abstain until conception can be planned. So I think that brings that whole issue into focus, because if you're infected at week 5, what happens? How do you know? Especially with the degree of asymptomatic cases.
And I think we're going to get a lot of new data after the Olympics this summer in Brazil, because historically the Olympics, you see a spike in sexually transmitted infections, and they would follow, there would probably be unplanned pregnancies, so we might get additional data after that.
And also, this is not a new virus. So this virus has been around for decades. And I'm just wondering, thinking about you, Dr. Smith, more, but there must have been some tracking of children who were infected prenatally with Zika virus and how they have done. I don't know if it's different from other cases of microcephaly or in the continent of Africa or other places where Zika virus has been in the past.
Yeah, I'm not familiar with anything in the literature that did a longitudinal study looking at people infected with Zika virus and seeing whether or not that there were long-term neurocognitive deficits. I think that this more came to the attention once the outbreak happened in Brazil, and now that they're following them forward. There haven't been any long-term studies that have been done previously.
So I just had a question to follow up on the literature that is reporting issues, obviously, during pregnancy. Is there any reports of the impact on newborns if they have contracted the virus as they're still somewhat developing?
So that's a very interesting question. If you talk to neurologists, the human brain doesn't stop developing until you're early to mid-20s. So theoretically, for some people, it's much later than that. But it would make sense that a virus that has a tropism for neurologic tissue might have an effect even after birth. We haven't seen that at this point, and it might be that that key point during the first and second trimester where they have the most deleterious effects is when the virus has its opportunity, and perhaps it doesn't have such an effect at a later time. That's also information that we'll probably get later as we track people in the next few years.
And the corollary to premature babies, you know, who really aren't supposed to be born yet, you know, and their brains are really still developing.
And there is a question posted asking about any special concerns for seniors. I'm not sure if that's getting at, you know, we all get more cognitively challenged as we get older, or any other special concerns for Zika infection with older people.
I would say just in general that with any infection, people who are older that have complicated medical conditions or who are more frail than the general population might have a more severe case.
And again, the death within an elderly person as well. Again, who had chronic medical conditions, so it's just one of those things. And I think we're going to see more about, you know, extremely rare baseline neurologic conditions. The ADEM has been acute disseminated encephalomyopathy, right? School ADEM has been associated with Zika, and so, again, since those cases are so rare baseline, I think it's difficult to say that, again, in older people that they're going to have higher incidence of that. Right now we have, in the U.S. and its territories, we only have 17 cases of Guillain-Barré syndrome, and while it's an interesting case to look at the Southeast Asian cases and to see GBS associated there in that case control study, going forward we really can't say who is at greater risk of GBS, but right now I believe it's only been in adults.
And just to highlight something Dr. Hardy mentioned here in Rhode Island, where we're hosting this webinar, I did go to the Department of Health website here, and there was very specific directions on collection and handling of this. I mean, recently there's been a pertussis little epidemic here and there, and for these kinds of things, you need the right medium, you need the right way this needs to be kept frozen and transmitted, and it was a very excellent description of what needs to be done when you're sitting there with the person in front of you.
Yeah, that's an excellent point. And it just highlights being able to really working with your individual health department, because both, the CDC and each health department does have very specific instructions, specific forms, can help you troubleshoot that, can really help you get the media, things like that, decide what test to send. So keeping in close communication with your state health department is important.
I don't know if anyone's dealt with the actual reporting of one, but say when you do an STD, the health department knows about it. They're going to know about a positive Zika finding. But with the STD, you need to give additional information about the patient, both demographically and clinically. And I would assume there's going to be some follow-up from the CDC or a form that a clinician would need to fill out to describe and help them know more about it.
Yeah, so when the testing is done, we do, our Department of Health and other Department of Health, we do have a case report form. And, all involved in developing that, and there is some information about, partners and things like that. So when you are sending testing or you're worried about infection, there is some of that similar information that does get collected, dates of travel, things like that.
So if there are no other questions that people would like to pose through the phone line or the chat function, we would like to thank you for participating in this webinar today, and I'm going to turn it over to Olivia for some last-minute information about CMEs and other things. Olivia?
Thanks, Dr. Campanile. I just want to thank everyone for a great discussion, Dr. Campanile, as well as all of our panelists. I just have a few last-minute announcements before we end today's call. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill it out, we would greatly appreciate it. Also, you need to fill out this evaluation in order to get your CEU. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with a link to the evaluation, as well as the link to the event page on our website. Again, we apologize for the quality of the slides. The slides that have been sent out in the data details email and the ones that will be sent out in the thank you email will be in better quality, so you can keep those as a resource. And again, the PowerPoint presentation is already posted on the page, and within the next few business days, the recording and a transcript of the webinar will be added as well. I just want to, again, thank you everyone for attending, and I hope everyone has a great day. Again, thank you to Dr. Campanile and all of our panelists. Thank you.